our hub team. I just would like to say that we are so pleased that you have elected to attend our clinic today. And I'd like to get to the first order of business, which is to share with you part of the outline of Project Echo Nevada and give you an overview, as well as touch on the hub and spoke model on which this clinic is based, and then give you an anatomy of the Echo Clinic in general, as it is based on a standard model along other subjects as well. So Project Echo Nevada, the ECHO, E-C-H-O, stands for Extensions for Community Healthcare Outcomes. Project Echo is a global telehealth platform, which you are participating in right now, and was started in 2010. So as I mentioned, there are several recurring ECHO clinics, which you are welcome to attend. We are clinic number 11, apparently. The hub and spoke model that I mentioned previous is that each ECHO clinic is comprised of a core hub team, which includes the facilitators, and a multidisciplinary team of subject matter experts. And you are going to meet the 5 subject matter experts of our hub team here shortly. So the spokes, or the target, that's you, include teams from urban and rural Nevada, and sometimes further out, who will be welcomed back every month to join us for a new topic. So this is not a traditional telemedicine model, provider to patient, but what we aim to do is increase access to care by facilitating knowledge transfer between subject matter experts and other people on the spokes. And primarily we do this through a case-based learning protocol. So as I mentioned, my name is Jonathan McCaleb, Hospice and Palliative Medicine physician and geriatrician with the VA Sierra Nevada Healthcare System, and Associate Professor of Medicine with the University of Nevada School of Medicine. And I am going to now have each member of our hub team individually introduce themselves and mention their background. And to get started, Kim.
Hello, everyone. I'm so excited about this ECHO project. I am currently the Vice President of Business Development for Harmony Hospice in Las Vegas. I am a Las Vegas native and have had the pleasure to build more than a couple of palliative care programs throughout the state and embedded in hospitals, as well as rural outpatient clinics and hospice from general inpatient units all the way, again, to rural services. I've been doing end-of-life care for over 15 years.
Thanks, Kim. And Jessica?
I'm Jessica Kate. I am a geriatric clinical pharmacy specialist at the VA Sierra Nevada Healthcare System, and I work in our community living center and with our hospice and palliative team, as well as home-based primary care and those hospice and palliative patients as well.
And I'm Stephanie McMullen. I'm a clinical social worker, and I'm a part of the VA Sierra Nevada Hospice and Palliative Care team.
And I'm Dr. Kelly Conwright. I am an attending physician in geriatrics extended care with the VA. I am also the program director for the Hospice and Palliative Medicine Fellowship through the University of Nevada, Reno.
Thank you. We will be having each of the spokes introduce themselves. The last point I have to make is the ECHO Clinic Anatomy, which is comprised of 3 main sections. First will come introductions from the hub and spoke participants. Second will be a case presentation, which in the case of our initial ECHO is woven throughout our presentation. And then the didactic, of course, the material that we have to present. Before we jump right in, I just want to acknowledge that many of you are palliative care providers yourselves and will be familiar with a lot of the information that's presented, while we also acknowledge that some of the information may be entirely new to others. So part of our goal is to provide support across the spectrum of providers and services available in the state, and be here as a resource for all of you. So without further ado, we are going to start the presentation.
Introductions.
Oh, the introductions. Thank you.
Yes. So we'll start off and go around the group here and have everyone introduce yourselves, please. So Dr. Lohr and Elko, could you start us off?
Hi, Steve Lohr. I've been recently hired as family medicine faculty for the Elko site of the UNR Family Medicine Residency. Prior to that, though, I've spent the last 7 years as medical director of the Horizon Hospice organization that was from all along the Wasatch Front, and then Cedar Cities, St. George, Phoenix, and Page. And I was board certified by the American Board of Hospice and Palliative Medicine that doesn't exist anymore from 07 to 14, but just missed the recertification. I didn't hear about the recertification, and so I just missed taking the exam. So now I'm I'm certified by the Hospice Medical Director Certification Board, but not, I don't have the CHQs in Hospice and Palliative Medicine.
Oh, welcome.
Thank you.
Thank you.
S. Tobin.
My name is Sarah Tobin. Can you hear me? I'm a social worker with Dignity Health. I was previously working in hospice and palliative care, and certainly this is very attractive to me. So working with our high-risk utilizer patients, this is certainly something that I want to need more awareness of as we all travel through there, this continuum.
Great, thank you.
Welcome.
Dr. Levy.
I'm Dr. Levy. I'm the geriatric physician and also medical director here at Project Echo. Very excited about our palliative care launch today.
Thank you. It's just a number, a letter with a number E105490. Go ahead.
Yes. Can you hear me?
Yep.
Yeah.
My name's Edward Finn, licensed clinical social worker. I'm the social work director at Pahrump Health and Rehab. Just wanting to know more about palliative care and that it is a required CEU for all social workers working in nursing homes. That's why I'm here today.
Wonderful, great to have you, thanks.
Thank you.
Willett from the VA. Looks like you're joined by phone, so that'll be *6 to unmute yourself. Kelly, do you know what that is?
No, I didn't.
Okay.
Oh, heard a sound.
No, that's okay.
Hello, can you hear me? This is Dr.
Yep, go ahead.
Hi, this is Dr. Shoemaker. I'm calling in from the VA. Obviously, I'm technically challenged, as you can see.
No problem. That's
But
why.
it's exciting to see my colleagues kicking off this new series, and I'm the program director of the Geriatric Medicine Fellowship.
Great, thanks,
Welcome.
Dr. Shoemaker. So then next up is McGill's from the VA.
Yes, this is Sarah McGill, and I'm the Hospice and Palliative Care Coordinator at the VA, and I also worked in community hospice for about 25 years.
Excellent, thank you.
Thank you.
Someone joined by iPhone. I'd ask you to unmute, so just accept that. We should be able to hear you. Okay, maybe a technical issue there, so we'll move on. It just said owner PC. Looks like you're on video with us. Hi, go ahead.
I'm good.
Could you let us know who you are?
So what am I clicking? He said to unmute. Oh, hi, I'm Erica. I'm a clinical manager here with Harmony Hospice. I also work with Kim here in Las Vegas, Nevada.
Great, thank you very much.
Thank you.
Andalyn Olson?
Hi, yes, I'm Andalyn Olson. I'm a dentist and I work for the Nevada prison system. Because of the structure of prisons, I don't necessarily, do palliative care, but there, as our prisoner population ages, I'm interested in how that will impact my patients. And yeah, so I'm sure I'm going to learn a lot.
Great to have you, thank you. Carmen Ziss? Oh. Carmen, are you there? Okay, we'll move on. A. Mueller? Do we have audio for you?
I think so. Can you hear me?
Yep, go ahead.
Okay, I'm the palliative care nurse here at St. Rose Sienna in Las Vegas.
Wonderful, great to have you, thanks.
Thanks.
Rajosh from the VA, actually doesn't look like we have audio for you, so make sure you click the little icon in the lower left corner and we'll be able to hear you. So next up is Lisa Franks. Lisa, are you there? Oh. Go ahead, Lisa, if you have a microphone, we should be able to hear you. Okay, maybe no microphone there. So if you just want to write in through the chat, letting us know who you are, that will work. So B. Funk is next.
Hi, I'm Beth Funk, and I'm the administrator in Harmony Hospice in Las Vegas. Been in hospice for about 25 years.
Great, thanks, Beth. P. Connor.
Hi, this is Phyllis Connor. I'm the palliative care nurse at St. Rose San Martin campus in Las Vegas.
Excellent, thank you. Dr. Shoemaker. Yes. Lewis J. from the VA. Looks like you're joined by phone. So *6 to unmute yourself and we'll be able to hear you.
Yes, I'm Janita Lewis from the Reno VA. I'm the case manager for our seriously ill, seriously injured veterans.
Excellent, thank you for joining us. We had somebody write in, Teresa Williams, social worker from the Reno VA. Thank you. Somebody just, their name is Staff. Are you there? Could you introduce yourself? Okay, maybe no microphone there. Monica Petronic, do you have a microphone? Yep, go ahead.
I do. Hi. I worked at Solari Hospice for 7 years as a social worker, and then I went on to Infinity Hospice, and I was the director of their palliative program there. And then from there, for the past 7 months, I have been the director of Renaissance Palliative Care. I actually created the program for them.
Welcome.
Thank you. Kenneth Renwick. So if you click the little microphone icon in the lower left corner, it should unmute you and we can hear you. Yep, go ahead.
Okay. I'm Kenneth Renwick. I'm a retired medical director of Tuolumne Miwok Indian Health Center by Yosemite. And I've been asked to get involved with the hospice in my older years here. So I wanted to learn more about it. I have some personal experiences with a sister who passed away at an inpatient hospice, which we don't have here, but we're talking about trying to get one organized.
Thank you for joining.
Thanks. We had Lisa write in, Lisa Franks, PA with Nevada Care Connect in Reno. Thanks, Lisa. Great to have you. Next up is Linda. Linda, are you there?
Linda, yes, I am. Linda Garrett here. I am a risk manager for some rural hospitals in Nevada through their LICON program, and many of them have long-term care and skilled nursing. So I'm here to learn more about it. I also have a mom who's in hospice care now. And so on a personal level, I'm really looking forward to learning more.
Thanks, Linda. Good to have you today.
Thank you.
McGee from the VA? Go ahead, I think we can hear you. Yep.
Is that me?
Yep.
Hi, Jonathan.
Hello.
You know, I'm just watching and eating my lunch. I'm in primary care in Reno, but just for your information, I was one of the original hospice physicians in California back in the 80s.
Oh.
And we had a huge hospice. We had like 150 volunteers. But I'm just tuning in to see what you guys are saying.
Good to have you. Thanks.
Yes.
Melissa?
Yes. Can you hear me?
Yep, go ahead.
Hi, yes. I'm a new nurse that just started here in New Horizon Home Health and Hospice. I moved from Texas. So I just started. I've been a nurse for 25 years, so I'll be looking forward in learning about palliative care.
Great, thanks. Good to have you. Mary Ann Brown?
Yeah.
Mary Ann, are you there? Yep, go ahead. Mary Ann, we could hear you.
Yeah.
Yep.
Yeah.
Go ahead if you could introduce yourself. Okay, maybe we're having some issues there. No problem. So we'll move on to, there's 2 people joined by iPhone.
Sorry. Oh. This is Kristen Black with Harmony Hospice. I'm a nurse liaison.
Great, thanks, Kristen. And somebody else joined by iPhone. It doesn't look like we can hear you. So we'll move on. Yep,
We're with Heart Rock Care. We're an in-home non-medical care facility, and we're just interested in learning more ways to improve our client care.
Excellent, thank you. Good to have you. Carrie Craig. Oh, Carrie, go ahead. Going back and forth on unmuting here. So it looks like you're joined by phone, so it'll be *6 and we'll be able to hear you. Yep, go ahead.
Okay, yeah, so I'm a master's in social work intern at the Family Medicine Center, and I would like to move into hospice palliative care when I finish, so I just want to sit in and hear what's out there.
Great, good to have you, thanks. Jennifer Duran. So *6 to unmute yourself, Jennifer. Go ahead.
Yes, hello. I'm licensed clinical social worker, and I'm the geriatric extended care social work supervisor here at the Reno VA.
Thank you for joining us.
Great, thank you. And last person is from the VA, ACCIND is your screen name. Are you there? Do we have a microphone for you today? Okay, no problem. If you could just write in through the chat. So, thanks everyone for introducing yourself. So many of you out there today, so that's fantastic. Yeah, this is just fantastic for our first session. So we'll get going here with the presentation. And throughout the presentation, please feel free to write in through the chat box if you have any questions, or unmute yourself and we'd be able to address those.
Hi everyone, thanks for joining us. I'm Dr. Rebecca Desflor. I am a hospice and palliative medicine fellow with University of Nevada, Reno School of Medicine. And I'm going to have my colleague Shalina introduce herself as well.
Hi, I'm Dr. Shalina Laws, and I am also a hospice and palliative medicine fellow through UNR.
And the other 2 names, Dr. Jonathan McCaleb is here with us, and one of our pharmacists, Jessica Kate, as well. We have no conflicts of interest related to this presentation. So I'm going to jump right in. Our objectives today are pretty basic for some of you. This is our first echo, and we just wanted to start out with sort of what we are, who we are, what we do, and then in future echoes, hopefully we'll get to dive in a little deeper. So the objectives, we're going to describe the scope and practice of palliative care, recognize the differences between palliative care and hospice, and identify the key members of the interdisciplinary palliative care team. I'm going to tell you a little bit about a patient we recently had with our VA palliative care team. We'll refer to him as Mr. O. So to get a little picture of who Mr. O is, he's a 70-year-old white male, Vietnam era veteran, and he was a very pleasant gentleman. He had lung cancer, and one of the complications of his lung cancer is that he had some very bad swelling of his face and upper right arm, and he was admitted to the hospital. At the time of his admission, he was receiving standard cancer therapy with chemotherapy and radiation, and our team was consulted to go talk to him to help with some symptom management, advanced care planning, and goals of care. He was later, once he was stabilized, he was transferred to a skilled nursing home level of care where he was hoping to get stronger and be able to go home where he lived independently. However, he declined, and he was eventually placed on our hospice service with the same palliative care team, and he eventually died on hospice. So we'll talk about more throughout the presentation about Mr. O. What is palliative care? We are a medical subspecialty that is person-centered for those with serious illness. We see patients in inpatient and outpatient settings, and really importantly, we follow patients throughout transitions in their care as well, just like Mr. O was in the hospital and then a nursing home. We also see patients in the outpatient setting when they are living at home as well. And we are a specialty that is added to the patient's care. They still see their primary care providers and their specialists, for example, oncologists or any other specialists that they may be seeing. And palliative care can be added throughout the course of a disease. We really encourage early referrals so we can get to know somebody at the beginning and then help navigate the medical system with them. And so it's really important to understand that it can be any type of serious illness or life-changing illness, not just cancer. So this graphic helps show that palliative care is with curative care. And as a person goes along the course of their illness, it changes from mostly curative care to more palliative care. And then right at the very end is when hospice usually gets involved, and then palliative care can continue after a person's death in the bereavement period as well. So you might still be wondering, what do we really do? So we listen to patients, and more than that, we elicit information from patients to find out what their values and goals are, and we help align their medical care with those values and goals. And sometimes we help guide them to management that is aligned with their care, and we also help guide them away from other management that might be against what their wishes are. We focus really on quality of life issues, and we address physical, social, emotional, spiritual, and even existential suffering. We help them manage their pain and other uncomfortable symptoms such as nausea, constipation, fatigue, and dyspnea, among many others. And then we really encourage and facilitate patient autonomy. We find that many people lose control or have a concern about losing control. It's very difficult in our age of medicine to really understand what's going on with one's health. So we really help patients with that. And then we also discuss advanced care planning, such as preparing living wills and helping people identify their healthcare powers of attorney. So who's in this team? I'm going to mention the core members. However, we are resource rich with the VA and also affiliated with the university. So not every palliative team will have all of these people involved. Some smaller programs might just have a physician and that's it. However, the core members usually are physicians and nurse practitioners and physician's assistants, nurses, RNs, LVNs, etc., social workers, and chaplains. Now we have lots of ancillary team members, which can include nursing assistants, dietitians, pharmacists, therapists such as speech therapy, physical therapy, occupational therapy, counselors and psychologists, and also volunteers. Oops, did I go too far? So let's talk a little bit more about Mr. O and his palliative care consult. So he was in the hospital, and the hospitalist team identified him as a patient that might benefit from palliative care, so they placed a consult. And we, as the palliative care team, went to see him only with his knowledge and agreement. That's really important. We don't force palliative care on anyone. They have to agree. So the people that went to see him, since we are a teaching institution, the attending physician on the team, the fellow, and the clinical social worker all went to go see the patient at the same time at his bedside, Mr. O. And as I said before, he was receiving chemotherapy and radiation for his cancer. So as we were talking with Mr. O, getting to know him a little bit better, we learned that he lived independently, and he was independent with things like dressing and bathing and meals. He was able to manage his own medications and finances, although he did have some memory problems or mild cognitive impairment. When discussing things that were bothering him, we found out, he was really concerned about the facial swelling, some shortness of breath, and his lack of appetite. We screened him for anxiety and depression, which were both negative. And then we discussed with him advanced care planning. He was able to identify a surrogate decision maker. And we talked to him about specific life-sustaining treatments, which could include ventilators, artificial nutrition, hydration, dialysis. Those are some life-sustaining treatments. And then we also filled out a PULSE, which is this pink form. Most of you out there probably are familiar with it, but for those who don't, it's a provider order for life-sustaining treatment. It's for both the inpatient and the outpatient settings. It's a physician order that's signed by both the patient and the physician, and it designates a code status and also some wishes for life-sustaining treatments. And probably in a future echo, we'll talk more about it as well. Mr. O, as far as his social structure was concerned, he didn't have a whole lot of biological family support, but he did have a community of friends. But being a very private person, he didn't reach out to them. So our social worker was able to really encourage and help him connect with his friends. And both Mr. O and his network, his community network, were very appreciative of that in the end. So the team made recommendations to his primary care team and also documented those recommendations, including documentation for hospice eligibility. And at that time, Mr. O did not qualify for hospice. So some of you might be wondering what that means. So for every disease, there's a little bit different criteria for hospice eligibility. Hospice is definitely not just for cancer patients. It's for all types of serious illnesses, but some of the criteria for cancer, since that's what Mr. O did have, are as follows. Metastatic cancer, so highly advanced cancer that spread, a decline in condition as far as the cancer despite therapy, the palliative performance score, which I won't talk a lot about, but it rates a patient's ability to perform tasks on their own, such as walking and eating, things like that. And then they have to elect to forego for their disease-directed curative therapy. However, palliative chemotherapy and radiation may still be included. Oftentimes there's not a payer source for that. However, at the VA, we are very lucky that we are able to provide those services, and it should be something that is considered for any patient.
Thank you, Dr. Desfor. I'm going to go over a few topics in terms of the difference between palliative and hospice, and sometimes we can get the two confused, and because there is a lot of overlap between palliative and hospice, but they are not the exact same thing, and there are some nuances that could probably be a lecture in itself, but we're just going to go over a few of them briefly. So with palliative care, like Dr. Desfor was describing, is that it can be introduced into a patient's care and added to their care at any time during their illness. So early on, middle, or at the end of their illness. And we encourage early consultation with the palliative care team. And at the end of this presentation, we're going to talk about a study showing the benefit of early palliative care and what that can actually provide for patients and their family members. So palliative can be included anytime during their illness, whereas hospice, per Medicare guidelines, is reserved for those patients who have a prognosis of 6 months or less. If their disease follows the trajectory and follows a natural course, we expect them to die within 6 months or less. So that's a big distinction between palliative and hospice care, that hospice truly is just reserved for those patients at the end of their life with a prognosis of 6 months or less. And palliative care is a little bit different in that it can be combined, like we saw in the chart, with curative care. So say a patient has a cancer that we believe can be cured. But as palliative care specialists, we can help with, say, aggressive symptom management while they're undergoing curative therapy with, say, chemotherapy, radiation, surgery. We can be there to help with pain management, management of nausea, vomiting, shortness of breath, any of those challenging symptoms that a patient might be experiencing while they're undergoing chemo or curative care, which is different than hospice care. With hospice, patients either forego seeking curative therapies because they're not in line with their goals of care, or in a lot of patients, there aren't any curative therapies that we can try. They are in stage, say, COPD or heart failure, HIV/AIDS. We don't have any curative therapies to offer them, but that doesn't mean that we stop treating the patient and or the family. And so we really manage their symptoms aggressively with hospice care as we do palliative, but with hospice, it is reserved for the end of life. This diagram does kind of hopefully help depict some of that they are different entities, but hospice care really involves bringing all of those modalities into palliative care, but for our patients in the last 6 months of life. But some patients don't qualify for hospice, yet we still want them to be able to get all those same resources to help manage their symptoms or their disease, and we can help do that under the umbrella of palliative medicine. One of the differences, and there is some similarities, is where can patients obtain hospice or get hospice care, and where can they get palliative care. And there are some nuances because not every community has hospice care and not every community has palliative care. So hospice care is reserved for the treatment of those patients at the end of life care in wherever they call home. So that could be a private residence, they could call home a nursing home, their home, an assisted living facility, their group home, wherever they call home, hospice will come to them. And there are patients where we can't manage their symptoms at home effectively, and therefore they can get hospice either in a freestanding hospice center, which is more rare, or in an inpatient hospital setting. But that is reserved for only those patients who have very, very challenging symptoms that cannot be managed in the home setting. Whereas palliative care is different in that some people and in some communities, although it is more limited, can get in-home palliative care. It is definitely more rarity here in Nevada than it is in some other states. But I am hoping that Nevada and its agencies will move to providing more in-home palliative care. But Patients, depending on the community, can also get palliative care in the outpatient clinic setting. So if you have a veteran who needs outpatient palliative care, please send them to us. We have a clinic once a week. And a lot of hospitals too have inpatient consult services. So like Mr. O, in the case, he was seen initially by our palliative medicine service as a consult service when he was in the hospital.
So there was a question or comment that came through about how homeless individuals would acquire this care.
That's a really great question, which kind of leads us into the next slide of who is going to pay for it. And so in our homeless population, it still kind of depends on, one, do they need palliative or hospice? And what their insurance status is. So for hospice, it is a Medicare Part A benefit. Part A pays for most of our patients, but that also has to do with just age, and a lot of our patients are on Medicare by the time they come to us. But Medicaid will pay for it if they're veterans. Regardless of their homeless status, the VA will pay for palliative care and hospice care. A lot of insurance companies will pay for hospice, and even our local hospice agencies, even if they are homeless or uninsured, will take on a number of patients, usually a certain percentage of patients, regardless if they have insurance or not. So please don't think that if a patient doesn't have insurance that they can't get hospice care, because a lot of them can still be managed in the community. Their homeless status is a little bit more challenging. Here in Reno, we don't have a homeless hospice house. There is one in Sacramento, so depending on where you're working or your patient population, they do have one there. But I think that's also where our social workers come into play and really, really help us trying to place these patients. Say it's a veteran who is homeless but meets hospice criteria, wants to adopt hospice as their plan of care, and they need skilled nursing home level of care. They can be admitted to a nursing home under hospice, and it's completely free. So I think that's where reaching out to our social workers is really, really important, and they are an integral part of both the palliative and the hospice teams.
And we have seen, not veterans, but other members of the community that are homeless or in the shelter receive hospice care at that setting if it's safe. And what's great is that the team can come on board and kind of help us, assist with placement and other things. So I think hospice is a really great problem-solving resource. So send the referral and let the hospice agency work it out.
If they're a palliative care patient and they're homeless, it can be a little bit more challenging, but it's still, in terms of receiving care, it's going to be important to look at their insurance status, who's going to pay for it. But once again, we still have social workers on our palliative care teams who can help us find and try to find resources in the community. So palliative care is paid for by Medicare Part B. So it's a little bit different. Patients may have a copay. Medicaid, the VA pays for palliative care, as we've discussed, in some private insurance plans. So there are some options out there for patients.
And I think we'd like to acknowledge from Dr. Lohr in Elko that he said for many years of trying that Salt Lake City established in between a consortium of hospice companies to provide homeless hospice care in a central location. So there's some really innovative models across the country of delivering palliative and hospice care to homeless people. And that could certainly be a topic for discussion on one of our echoes if the interest is there.
And some of the most innovative team members, being hospice nurses, can tell you stories about patients that they've cared for on hospice who are homeless. And having had the privilege of working closely with hospice nurses, So a story that comes to mind is a nurse who just met a hospice patient in the community at a set location once a week. So there's a lot of ways of being resourceful and connecting with people, which really ends up driving the care that they receive.
So back to Mr. O. Mr. O was initially seen by our palliative medicine team on the inpatient setting, and like Dr. Desfor had said, he was then moved to a skilled rehab center with the goal of receiving physical therapy while getting chemo and radiation to treat his cancer, so that he could then return home and live independently. Unfortunately, Mr. O continued to decline, and his functional status really declined. He also developed some complications from the chemotherapy and the radiation, most notably inflammation of his lungs, which then contributed even more towards his shortness of breath or dyspnea. And so he really kind of declined in terms of his functional status, to the point that his oncologist wasn't able to provide any more chemotherapy. So he did receive some palliative chemotherapy and radiation to try to shrink this lung cancer, this mass, to relieve some of the swelling. And it did help, but unfortunately he wasn't able to continue. But being under the umbrella of palliative medicine, we were able to try to really manage some of those symptoms that he was having in terms of pain and shortness of breath. And then when he was no longer able to continue with his potentially curative or palliative chemotherapy and radiation, the patient at that time decided to switch over to hospice. And because we had initiated palliative medicine as part of his complement to the team taking care of him early on in his course, we were able to have that rapport with him and really have a seamless transition from his palliative and oncology teams taking care of him to the hospice team taking care of him. And so that was a real, it was a huge benefit to him to have that team who already knew him, who was already managing those symptoms really aggressively, continue with that care now under the umbrella of hospice. And one of the main symptoms, as you can imagine, with a patient with lung cancer and now terminal lung cancer, he had a lot of dyspnea. So Jessica, our pharmacist, is going to go through some of the pharmaceutical medical options that we were able to treat Mr. O with in order to alleviate a lot of his shortness of breath symptoms.
Thank you, Dr. Laws. Like we all know that there's a lot of symptoms with palliative medicine and end-of-life care, but we decided just to focus on this one for now and can do deeper dives into both this and others moving forward in other echoes. But for pharmaceutical options for dyspnea, our gold standard is morphine or opioids. And if you have a patient that's opioid naive, we start low, and typically low doses throughout the day can be very beneficial. Second line, or if they have a large anxiety component with their shortness of breath or air hunger, then we can use benzodiazepines and lorazepam. We typically like to use in our elderly patients. It's a shorter half-life, and some of the side effects are lesser. And we always want to start low and go slow in our elderly patients for both benzos and opioids. Inhaled bronchodilators can have a place. Typically, we only will see result if they have an underlying obstructive disease, so COPD. Otherwise, we don't typically see the bronchodilators providing much relief. And that kind of goes the same with supplemental oxygen. There's really mixed data out there, and mostly if they're not hypoxemic, then there's really no role for supplemental oxygen in dyspnea as well. Some non-pharmaceutical options, it's very patient specific. You can reposition them, having them sit up more if they're able to, putting a fan on the face to elicit more air into to help with the breathlessness, adjusting humidity in the room. So in the state of Nevada, we're very dry, so providing more humidity, or in other places possibly less, and then avoiding triggers, smells, physical activity, things like that is also very helpful.
Thank you. So like I had alluded to before, we, as palliative medicine physicians, we are a little biased, but this study does support us in that it shows that early palliative care for patients can be beneficial. So this was one of the landmark studies in our subspecialty, and it took patients with a new diagnosis, so within 8 weeks of diagnosis, of metastatic non-small cell lung cancer, and it randomized them to one of two arms. So one arm was the standard treatment group who received oncology care for their non-small cell lung cancer, and the treatment arm received both the standard of care with oncology, but also early palliative care. And the definition of early palliative care was that once they were randomized, they met with the palliative care team within 3 weeks of being randomized into that group, and then monthly thereafter. And they looked at some of the outcomes and compared the two arms. And so those patients that received both the standard of care with oncology plus palliative care on top of their standard care had better quality of life, which was measured on the functional assessment of cancer therapy lung scale. So they had a higher quality of life. They also had improvements in their mood, which were statistically significant as measured on the hospital anxiety and depression scale. They also had increased median survival by almost 3 months. And it was really interesting in this study in that those patients who received early palliative care not only had longer survival times, but they also received less aggressive care at the very end of their life. And so they described that as chemotherapy within the last 14 days, hospice referral within the last 3 days of life, or no hospice referral at all. So it was pretty remarkable, and it really showed the value of our specialty in that early referral and integrated management of palliative care into this specific patient population improves mood, quality of life, and survival. And so we hope that this can be replicated with other diseases, because this was specific to non-small cell lung cancer. But we've kind of taken this, as have our oncology colleagues, and really tried to use this to integrate palliative care into patients' care teams and their models earlier on, because it is our goal to increase quality of life. Obviously, mood is part of that, but then also to see longer survival times was pretty remarkable. So in summary, palliative medicine is a subspecialty in which we focus on aggressive symptom management, quality of life, and not just end-of-life care. So it is a distinct entity from hospice, which is reserved for those patients in the last 6 months of their life, but there is a lot of overlap between palliative and hospice medicine. And with both teams, and as we discussed, it's really a team-based approach to medicine for our patients. It's not just physicians, it's not just nurses, it is an entire team that is treating both the patient and the family. So we'd like to open it up to any other final comments that the Hub team might have and or questions.
Just briefly, I think that one of the key and distinguishing features of Mr. O's case was that he was referred to our team through the inpatient internal medicine service. But for those folks out there, We just want to make sure that not just early referral, but also from any team members in the hospital. So we get also a lot of referrals from nurses. We get referrals from the social workers, from case managers, from everyone. So if you're on any healthcare team, just getting your voice heard and recommending a palliative care consult is definitely advised.